Hi and welcome back to another video of Medic Notes. This video is on peptic ulcer disease. Its incidence is increasing worldwide but decreasing in developed countries, maybe because of increased medical anti-ulcer and H. pylori treatment or decrease in smoking. Duodenal ulcers develop in 0.8% of population per year. Gastric ulcers develop in 0.2% of population per year. Peak age for duodenal ulcer 25 to 50 years old, gastric ulcer in more than 50 years old. Male to female ratio is 3:1 for gastric ulcer and 4:1 for duodenal ulcer. The causes of peptic ulcer disease include Helicobacter pylori infection. Smoking and alcohol decrease pyloric competence, leading to more acid in duodenum. NSAIDs and corticosteroids affect mucosal defense. Stress like burns and major surgery. Associated diseases like alcoholic cirrhosis, chronic renal failure, COPD, and hyperparathyroidism. These conditions increase calcium, hence increase gastrin, causing peptic ulcer. Familial, HLA-B5 and blood group O people are at risk. And lastly, gastrin secretion. Helicobacter pylori infection. It is a gram-negative flagellated spiral microaerophilic bacillus. About 50% of the world is colonized with H. pylori. It produces the enzyme urease, creating an alkaline microenvironment. Associated conditions are duodenal and gastric ulceration, atrophic gastritis, gastric malt lymphoma, ischemic heart disease, and gastric cancer. H. pylori leads to gastric mucosal injury in several ways. It produces a toxin which induces vacuole formation in cells. Produces ammonia which is toxic to gastric epithelial cells. Adheres to the epithelial cells and disrupts the cell surfaces using protease and lipase, thus allowing acid to diffuse into the cell. And also increases gastric acid secretion. Clinical presentation. Patients with duodenal ulcer present with epigastric pain during fasting, pain at night 2 to 4 a.m. Relieved by food and antacids. Relapsing and remitting, 2 weeks of symptoms every few months. Penetrating posterior ulcers cause severe constant pain that radiates to the back. And 10% are painless. Whereas people with gastric ulcer present with epigastric pain induced by eating, nausea and vomiting, and iron deficiency anemia. Investigations. Endoscopy is the gold standard, can diagnose inflammations and gastric ulcers can be biopsied. 10% of gastric ulcers are malignant. At least 6 biopsies should be taken from edge of gastric ulcer. CLO test to test for H. pylori. Antral biopsy placed in a culture medium containing urea and phosphorus monohydride sensitive indicator. If H. pylori present, ammonia is produced and pH indicator changes from yellow to red, indicating a positive CLO. Carbon-13 urea breath test. Ingested urea labeled with non-radioactive carbon-13, split into ammonia and C labeled CO2 by H. pylori. Labeled CO2 can be detected in patients' breath samples using mass spectrometry. For medical treatment, if CLO test result negative, treat with full-dose proton pump inhibitor for 1 or 2 months. If result positive, treat with eradication therapy, which include amoxicillin plus clarithromycin plus lansoprazole or omeprazole, or clarithromycin plus metronidazole plus lansoprazole or omeprazole. Prescribe PPI or H2 receptor antagonist long-term and advise stop smoking. For surgical treatment of gastric ulcer, indications of surgery are failure of medical treatment such as non-healing or frequent relapse of ulcer. Complications like hemorrhage, perforation, or obstruction, and any non-healed gastric ulcer. Principles of surgery. Remove ulcer along with the gastrin secreting zone of the antrum. Most recommend a formal gastrectomy involving at least distal third of stomach. Types of surgery include Billroth 1 and 2. Vagotomy, pyloroplasty and excision of ulcer. Vagotomy, antrectomy and Roux-en-Y. Whereas for surgical treatment of duodenal ulcer, aims to reduce acid secretions of the stomach by dividing the vagus nerve. Elective surgery is seldom performed now due to successful medical treatment. Types of surgery are truncal vagotomy, selective vagotomy, and highly selective vagotomy. Post-op complications. Problems around anastomoses are obstruction, leak, esophagitis, bleeding, alkaline reflux gastritis and vomiting. Problems due to vagus nerve transection are diarrhea, gastric atony, gastric outlet obstruction, and gallstones. Problems due to loss of stomach capacity and function are dumping, vitamin B12 deficiency and IDA, and malnutrition. Other complications are gastric remnant cancer and pancreatitis. Dumping syndromes are a group of cardiovascular and GI symptoms resulting from rapid gastric emptying after truncal vagotomy and pyloroplasty or gastric resection. Early dumping is due to hypovolemia, late dumping is due to hypoglycemia. Early dumping is due to hypovolemia. The proximal small bowel is dumped with gastric contents, rather than the contents being squirted through the pylorus over a period of 1 to 2 hours, so there is huge amount of bile, pancreatic juice and succus entericus into the upper GI tract, which causes a large fluid shift. This tends to improve with time and small dry meals. Subcutaneous somatostatin injections can limit symptoms. Features start within 5 to 45 minutes of eating. Patients complained of sweating, palpitation, dizziness, flushing, tachycardia, abdominal pain, nausea, and diarrhea. Whereas for late dumping syndrome, it is due to rebound hypoglycemia in response to an abnormally high level of carbohydrate in small bowel. This stimulates release of enteroglucagon, which sensitizes islet cells to stimuli, resulting in overproduction of insulin and symptoms of hypoglycemia. Features occur within 2 to 4 hours of eating. Patients have sweating, palpitation, dizziness, and tachycardia. That's all for this video. Thank you.